My name is Andrzej Jakubowiak. I'm here at ASCO discuss with you the results of extended treatment with KRd combinations in newly diagnosed myeloma, in which we combined and incorporated into the KRd treatment transplant. We have previously reported that KRd, Carfilzomib, lenalidomide, and DEX is extremely active, with over 50% of stringent complete responses after extended treatment, and with outstanding progression-free survival. Just to give one example, at 3 years, only 21% of patients would relapse, newly diagnosed, including patients who are with high-risk disease. So very active and very much recognized combination. We looked at that study results not as a reason to replace transplant, even if we thought that the results were better than with any other combination and transplant, but as a backbone for maybe further advancing our treatment outcome by incorporating transplant into extended treatment with KRd. So instead of continuing with KRd as it was in the original trial without transplant, this time those patients who are interested and candidates for transplant received transplant after 4 cycles of KRd, in a way interrupted KRd treatment, but then after they recovered from transplant, they resumed KRd treatment for additional 14 months of KRd therapy, and only after that time of total 18 cycles of KRd, they would resume maintenance with Revlimid alone. So the results are very exciting, and probably the reason why that particular study, which was led by University of Chicago but was conducted by a number of centers at Multiple Myeloma Research Consortium, was selected for oral presentation. So first I want to say that the study objective was to see as a surrogate evidence of improvement at the rate of stringent complete response, meaning lack of evidence of any detectable disease by immunofixation and bone marrow at the completion of 8 cycles, with or without transplant. In our original trial without transplant, at this point, about 30% of patients had stringent complete response, which was already very good. That number increased over time, but not much to slightly over 50%. With transplant, in our current study, which we present, at the completion of 8 cycles, 70% of patients are in stringent complete response, and even higher percentage of them are having no evidence of minimal residual disease. And that's very mature now, with over 20% of patients reaching that goal, and giving us sense in non-randomized fashion that in fact transplant improves this outcome. But what is most exciting, that when we continue treatment of patients, the depth of response continues to increase. At the end of KRd treatment, with now a relatively limited number of patients, still many of them earlier in the phase of treatment, but we see over 80% of patients achieving no evidence of any residual disease by immunofixation on MRD. In over 80% of percentage of patients, the results which we've never seen in any other strategy or treatment, which is very exciting for us, and I think gives us a sense that maybe we can really truly get as close to, if not objective cure, a functional cure for extended period of time. The period of follow-up is short. So at 11 months, more or less, we have only 1 progression out of almost 60% of 60 patients enrolled into the study. So that gives you a sense of having a very good, not only depth of response, but also very durable response. And I am very certain that next updates in a year or in 2 years will continue to give us a sense of great advancements of treatment of transplant candidates with this strategy. I think that number one, that we can potentially reach the the goals which we have not even dreamed of. If we can tell to our patients that you have probability in 8 out of 10 that we will not have any detectable disease in say 1 year of treatment with any even most sensitive method, and that's what we predict right now, this is a great achievement. Then we can tell to our patients that while we don't know whether anybody in this group is cured, we have seen in the past patients who never really relapse. And if it happened in 20% of patients achieving stringent complete response, I can safely assume that maybe higher proportion of patients nowadays, in this particular study will be able to stay in indefinite remission, which by any other definition may potentially at some point mean for some of them that they may be cured. I'm not trying to claim or say that we are curing patients with this strategy, but I think we are showing those results because we think we are getting closer, and we need to really figure out how we can validate those results in maybe a more rigorous way by, number one, following longer these patients, what we have on this study to start with, but potentially later on in randomized evaluation, which would potentially validate the strategy for at least some of the patients that as close to superior as possible. I would also add that it may practically mean that if there is a confidence of patient and physician in this data, current NCCN guidelines include as category 2A, which is as high category as it gets outside of clinical trial. RVD is in the same category, and CyBorD and some other regimens, triplet regimens, which we use in newly diagnosed myeloma. KRd is also listed as one of the top choices by our national guidelines. So if there is interest and potential confidence in those results, there is a potential for moving on this treatment even before we have evidence from randomized trials that this is an improved strategy. In fact, in my center, if we don't have ability to enroll patients into this trial, I am treating patients along this pathway already. For the most part, the insurance agencies have not given us hard time to really use this strategy. So we have excellent results, bringing us as close to what we would like to see as outcome in myeloma. True in patients who are transplant candidates, and true patients who don't like transplant, they may want to not necessarily go this route, but those who have confidence in transplant, and this study seems to be supporting the role of transplant even in the context of as good therapy as KRd, that could be one of the choices which is already in their disposal, and it can be potentially taken sooner rather than later. And I think Dr. Zimmerman and I and all the investigators of this particular trial would be happy to share our experiences with patients and their doctors if those type of choices will be potentially considered.